So the final session of this conference is on policy and evidence in policymaking and value-based healthcare. Just to give a highlight on at least where the Kingdom of Saudi Arabia is heading, the hosting country for this conference. I'm a family physician and I'm a believer in EBM, as whoever attended the previous session it was noted. But I'm also have been involved in the healthcare transformation in the kingdom, where the core of this healthcare transformation is value-based healthcare, where evidence-based, optimal, efficient care should be provided and proven by indicators and measurements that are used in value-based healthcare. So in this session, we will have the great Dr. Muir Gray, who is very well known. He will highlight for us the paradigm shift from evidence-based healthcare to value-based healthcare. So welcome, Professor Muir Gray, and kindly put his slides for him. So then our next speaker would be Dr. Marleen Kunneman. So I hope I pronounced it properly.
Yeah.
And she'll talk to us about making care fit in the lives of people with chronic conditions. Again, that is a very important topic, especially for the region where here in Saudi Arabia, as well as I think the whole GCC region, where we have humongous numbers of, I mean, a lot of obesity and sedentary lifestyles leading to a lot of challenging chronic diseases, diabetes and its complications. And this also reflects on quality of life and on cost of care. So please go ahead, Marleen. Thank you.
Okay. Just to double check whether you can see my slides. If not, then just give me a heads up. Thank you so much for that introduction and also for the opportunity to present our work today. I have no conflicts of interest to report. My team and I do not receive any funding from for-profit organizations. For too many people, their care plans are designed without fully accounting for who they are, the lives they live, what matters to them, or what they aspire to achieve. In other words, these care plans are designed for patients like this, but not for this particular patient. In the next 20 minutes or so, I would like to present to you ways in which patients and clinicians can work together to make care fit for each individual person. And what is the role of evidence in doing that? Well, rather than collecting evidence and trying to implement the evidence in practice, a push of evidence into practice, if you will, I will focus on collaboration on a micro level with the purpose of advancing the patient situation. In such a collaboration, I believe we don't push the evidence into that conversation between a patient and a clinician, but they work together and only pull in the evidence they need in order to improve the patient's problematic situation. I am talking about a collaboration in which language, communication, relation, respect, and people matter, in which care is not a noun, it's not a product, it's not something that we can provide or deliver. Care is a verb. It is something that we do. We care in a way that fits. I will draw specifically from 3 different projects in this area from our team. First, an online partnership meeting with experts, then a literature review, and finally an observational study in which we analyzed video recorded encounters between patients and clinicians. And I will walk you through how these 3 projects help us shape the concept of making care fit. And then I will end with some of our next steps. So early last year, we started with a partnership meeting. This was an international and interdisciplinary meeting with a group of patients, their caregivers or loved ones, clinicians, researchers, policymakers, and healthcare designers. And they came together over the course of 2 days to identify and reflect on the necessary conditions of making care fit, and also to identify future priorities. We had 25 participants from 8 different Western countries, and we used several co-creation methods to draft a manifesto in which we call on our peers to support and foster efforts of making care fit in daily practice. So what does this manifesto say? Well, in short, the manifesto states that in making care fit, we need to maximally respond to the patient's unique situation and their priorities. We need to make sure that we minimally disrupt their lives, their loves, and their social networks. This all needs to be done through collaboration, an ongoing and iterative process of collaboration in both the content and the manner. We call these essential dimensions that you can see on this slide, or essential conditions. We call them dimensions, and this is a term that I will use throughout the presentation. So the manifesto formed the base for a systematic review of the literature, which was amongst the priorities identified during the partnership meeting. And the aim of the review was to identify, characterize, and summarize extant measures of patients and clinicians working together during clinical encounters. We included almost 200 papers in the review, and we found more than 140 measurement instruments with 1,243 items relevant to assess efforts of making care fit. The unit of our analysis were the single measurement items, so we extracted them from their original scales, and we coded each of these items twice. First, we coded them into one of the dimensions that I just discussed from the manifesto. And then in the second round, we coded each of these items for their main action verb. So what kind of behavior are we actually assessing when using these items? So here you can see the dimensions again from the manifesto. So the patient situation, their priorities, their lives, their social networks. We're talking about collaboration in an ongoing and iterative manner. And then in this review, we also identified a new dimension, which was in the importance of time and pace. So what do we find? What we found was that almost 2/3 of all the items evaluated the collaboration between patients and clinicians. So more or less process measures. In contrast, only 2% of all the items evaluated the possible impact that care can have on the patient's lives. So if I'm talking about collaboration, what does this collaboration look like? Well, in literature, this is often called shared decision-making, and patients and clinicians can work together to make decisions about health or care. And there are several models out there, but usually these models make a distinction between 4 different steps. First, clinicians foster choice awareness. This means that they indicate that there's more than one medically reasonable option and that whatever we do depends on what matters to the patient. Second, the patient and clinician discuss the relevant options, their pros and cons, also the likelihood of these pros and cons occurring. Third, they discuss what matters to the patient. And then finally, they make a decision about what is best. And I can talk for hours about shared decision-making, but I will just keep it to this single slide today. If you want to know more, then please get in touch with me. So going back to the review, after coding each of the items into the dimensions, we also coded each of the items into action verbs. We identified 27 action verbs, and we grouped them into 7 overarching action terms. As you can see here, facilitating patient involvement, adjusting to the individual patient, providing information and gathering information, making a human connection, giving attention, and self-efficacy building. So what we saw was that about 1/3 of all the items evaluated the act of providing information. And although it wasn't really surprising, because when we look at most research and implementation projects in terms of shared decision-making or patient-clinician collaboration, we see that they have quite a heavy focus on knowledge. But I have to say that it was quite disappointing, because while information is necessary, it is definitely not sufficient, perhaps almost never sufficient. And oftentimes, I think the best way to advance a patient's situation may not even be rational or information focused. The best way forward may just be because it makes emotional sense, or because it makes practical sense. Can I even make this work in daily practice or in daily life after I return to my home? So at the same time, we see that, for example, self-efficacy building, which is very important for all chronic conditions, or perhaps for care in general, was assessed by only 3% of the items in our review. Or adjusting care to the individual patient, this was assessed in only 5% of all the items. So we found large differences between the dimensions and the actions. And we see that current research is mostly focusing on evaluating the content of collaboration and the act of providing information. Our manuscript is submitted, and the manuscript includes a table with all the identified items, so 1,243 items, sorted by their dimensions, as you can see here in the columns, and their action verbs, as you can see here in the rows. And the purpose of this table, well, filled in with all the items, of course, is that researchers can use this table to determine their outcomes and to decide or choose to assess a certain dimension across all the action verbs. So pick all the items in one particular column, to assess a particular action verb across all the dimensions. So look at one particular row, or to look at a unique combination of a dimension and an action verb. So at one particular cell and the items in that cell. So we had the expert views from the partnership meeting. We know from the literature very diverse ways of assessing efforts of making care fit. The next piece to our puzzle was to look at real life conversations between patients and clinicians. And this is a method that we use quite often in our research projects. For this study, we are currently analyzing recorded conversations between people with diabetes and their clinicians during their annual visit at the Diabetes Care Clinic. It's an integrated practice unit of our university hospital. For this, we use reflexive thematic analysis to uncover predefined or additional dimensions and behaviors relevant to making care fit. And from a recording database, we are selecting a purposeful, diverse sample in terms of both biology and biography, so also the life story of patients. And we expect that we will need around 20 conversations to reach data saturation. So our collaborative was able to incorporate different perspectives into the concept of making care fit. And I'm also very proud of the central role that people with lived experience play in initiating and prioritizing our projects, which I believe makes our project very practice relevant. So taking all these 3 projects together and adding what we know from existing literature, for example, on shared decision-making, what is making care fit? Well, making care fit is, rather than applying high quality and reliable evidence on group groups of patients like this, making care fit is a way to design care plans for this particular patient sitting in front of me right now, and to draw the necessary evidence, both scientific but also personal evidence from the patient, into that collaborative design. Efforts to make care fit take place at the point of care, mostly during clinical encounters, and at the point of life in the patient's personal environment. And the patient, or sometimes a loved one, is usually the one person bridging whatever happens within those walls of a clinic and whatever happens outside of that clinic. And I think we can all, well, we know or we can imagine how difficult it is to adjust care to an individual person if we don't know anything about that person or about their lives or their priorities. So it's crucial that we find ways excuse me, during the encounters to discuss whatever happens outside of the walls of a clinic, because whatever is left undiscussed is also left unconsidered when designing care plans. So making care fit can be divided into several dimensions. First, care that fits maximally responds to the patient's unique situation. And this means their personal and their medical backstory, and also how these two may be intertwined into a problematic situation. It also maximally supports patients' priorities, their goals, their needs, their wishes, and their worries. At the same time, it minimally disrupts patients' lives and those things in life that make life worth living in the first place. It takes into account the work of being a patient, the impact of the condition or the care on the patient's lives, and the patient capacity. And I think especially in chronic care, the use of devices and technology can both add to the disruption or relieve this disruption. It also minimally disrupts patients' social networks, their communities of care, and their loved ones. And to achieve this, patients and clinicians work together, first in the manner of collaboration, tailoring the conversation to the needs, abilities, and the situation. They build and maintain a relationship, and this is a relationship on which they can fall back on whenever there are setbacks in care. This relationship is based on mutual respect, on willingness to accept each other's contributions, on empathy, humanity, and dignity. They also collaborate in the content of their conversation, applying the steps of shared decision-making, fostering choice awareness, discussing the information and the preferences, and also discussing the anticipated impact of care options on the future. They may use conversation support tools or decision aids or information leaflets for this purpose. In a successful collaboration, we oftentimes hear people talk about how there was a certain connection between a patient and a clinician. And sometimes that goes, well, usually probably that goes beyond mechanically going through the motions of taking the right steps at the right time in the correct sequence. Checking the boxes is simply not enough to care. And all this should happen in unhurried conversations. I'm not talking about slow conversations, but unhurried. In a way in which an ongoing and iterative process care is continuously modified as the patient's personal or medical situation changes. So I have a few minutes left to discuss some of our next steps. Well, we've asked young adults living with type 1 diabetes about their efforts of making care fit. And we chose this group because they face age-specific challenges as they become independent and their life changes constantly as they develop their identity, start higher education or entry-level employment. pursuing sports or other hobbies, and initiating and establishing their own households, relationships, and families. And this is what some of them said. You want to live a fun and spontaneous life, but you have to nonstop keep an eye on your sugars. Food, everything you have to do then. That's why I sometimes skip my meals. I bolus less insulin to prevent hypos. And I use a do-it-yourself looping system. I did tell my clinician, but he wasn't interested. So we know from research that young adults with type 1 diabetes have relatively poor biomedical and psychosocial outcomes. Let me just see if this works. No, it doesn't. There was supposed to be a graph here that shows that HbA1c levels are higher in younger adults compared to other age groups. But strikingly, these HbA1c levels are also higher now than they were a decade ago. At the same time, our own research showed that 3 of every 4 young adults living with type 1 diabetes indicate that their investments in time, energy, and efforts in healthcare are unsustainable over time. And that's a lot. That's about twice as high as for other people living with chronic conditions. This means that at some point, aspects of care will not be implemented anymore. And then we label these patients as non-adherent or non-compliant. Or the treatment is actually implemented, but only at the cost of those things in life that bring them joy or are supposed to bring them joy. This is not only wasteful, this is harmful. So what do we want to do about this? Well, early next year, we will start with a new 4-year project for which we recently received funding to uncover what the most important and easy to implement efforts are of young adults with type 1 diabetes and their clinician, both at the point of care and at the point of life, to make diabetes care fit. We will use a combination of several methods, including large-scale surveys, a photo voice study in which we ask young adults to take pictures and show us the efforts and the impact of care, which may sometimes be difficult to put into words. Third, a study in which we record and reflect with young adults and their clinicians on what happened during their own encounters. And then finally, an expert meeting to prioritize and estimate the feasibility of implementing exemplary efforts on a larger scale. 1 second. So that brings me to the end of this presentation. I have discussed with you how efforts of making care fit take place at the point of care and at the point of life. And the method of care, of making care fit, is through collaborative conversations. These are currently quite heavily focused on information, but eventually the goal is that for each patient, care plans make intellectual or rational, emotional, and practical sense. Because even if care seems right from a medical perspective, if care doesn't fit for each individual person, we may be delivering care without actually caring. That leaves me with one request. There's a QR code on this slide. I ask you to scan this QR code. It will bring you straight to the Open Access Manifesto published in BMJ Evidence-Based Medicine. I have discussed with you everything that is in the manifesto, but I ask you to send it to someone else, and perhaps together we can improve ways in which patients and clinicians can work together in the arts of medicine and in designing care plans together that fit. Thank you very much.
Thank you so much, Marleen. That was really amazing. And I really love the way, even the slides, they were really attractive, and the cartoons or what the clip arts that you've used, they're really amazing. And I love the project. and congratulations on getting the fund for the next 4 years. You focused on an area that we don't usually see much evidence on, but we know it as a family physician, the relationship between the patient and the healthcare provider, and what goes wrong in that area, which is not easy to be measured, really. So I really congratulate you. Amazing work. And we hope to hear from you after this 4-year project is evaluated. And the floor is open for questions and answers. Let's see the chat box. There's okay, so far no questions. People are thanking. Yeah, I think, yeah, it was great. Thank you.
Thank you.
So any questions or comments from the audience? So you can put it in the chat box. So I think, yeah, it's quite late. So it's been an amazing day, but a bit long. So with this, then I think this is the final presentation in this conference. And it was an amazing closing presentation. Thank you again, Marleen. And thank you thanks to the organizing team, Prof. Lubna, the chair. And I leave the floor for you, Prof. Lubna, for your comments and closing remarks. Thank you, everyone. Thank you, Marleen.
Okay, so thank you very much, Marleen, for the presentation. Thanks, Dr. Noha and Noha for being here as well. I think it's becoming very natural that we are together ending this conference. So that's really nice. Unfortunately, we couldn't get in touch with Professor Muir-Gray, so that would be the end of the conference. It has been a tough, busy, I would say, not tough, 2 days. And I know that not all of us have seen all the sessions. So even if when we end the conference now, it's not the end of the conference in reality, because you would have more time to watch the videos, and possibly I would see that this is more of a beginning rather than an end. And just I would show you one slide here.
Can I just, there's one question for Marleen.
Oh, yes, sure, yeah.
From Abdurrahim Al-Mustafa. He says, I don't know if you can read it, Marleen. He says, in regard to cost, is it costly? I think he means, is the cost high for CareFit for one patient, or is it a peer group is more cost effective?
That's an excellent question. I don't think we know a lot about the effects that patient involvement has on cost of care. And I think it also really depends on the care system where you're at. In some systems, patients hardly pay anything out of pocket. So decisions that are made are usually made on a group level. Do we feel as a society that this care should be offered to patients at all? And in other systems, people actually pay a lot. I think in that case, it is especially important to have cost conversations for each individual patient, because more often than not, it is actually a factor in why people are having trouble implementing care into daily life. And this is also something that we're not usually comfortable discussing during clinical encounters. But it is something that should be considered when designing these care plans. I would argue that we need to define as a group what we want to offer to groups of patients, but then also look at individual patients and see whether these treatment plans actually make rational, emotional, and practical sense for them.
Okay, thank you for that clarification. But I have to say that with giving longer consultations, I'm a person who still suffers. I've been practicing for a very long time, and I still suffer that people, I mean, administration don't like it when I take a long time in every consultation. But I think, especially with patients who are older and sometimes even the younger ones, they really need time to build the relationship and then maintain it, and a healthy and drug-like relationship or therapeutic-like relationship. So, but the current challenge, I believe, is the cost measure. So for us, for the new transformation system, cost will be a challenge. But thank you for the comment and clarification. Marleen, back to you, Prof. Lubna.
Okay, thank you very much again. Thanks to all for conducting this session. I think that was a nice closure where we talk about evidence and about science, but we shouldn't be forgetting the patient-centeredness when we are dealing with patients. And it's again the three circles that are known about evidence-based healthcare. So we shouldn't forget about what really patients want. And I hope that for all the participants who are still with us, I think we're having a large number who are still around, and I'm glad that they are sustaining the effort, making the effort in order to still continue with us. So we have something like 180, which is fantastic. And I hope that you have liked the conference, or at least you found that you've learned something. It helped you to reconsider things and plan for a better way of learning about evidence-based healthcare, or implementing it, or generating it, or whatever. I think we need to learn how to work together in a better way. I think this was one of the clear messages in most of the sessions, how to coordinate the work and how really to partner with others, and how to make use of the existing bodies for the benefit of our patients and our society. I'll just share the analysis of patients here. The participants. When we started the conference, we told you that we really wanted this conference to be an international conference, and this was the distribution of the speakers from all continents. Now, when it comes to the distribution of participants, we have from almost all continents at least one participant. South America we didn't have, but the majority, of course, are from Saudi Arabia and the Gulf region. And it just makes me think, how can we better propagate the message to others? That's one thing. And if we are having this critical mass in Saudi Arabia who are interested in evidence-based healthcare, how can we better work together, and how we can really move forward in the same way that we have heard of the success stories from other speakers this afternoon or this evening? I think there is a potential. I mean, if half of this number, or 1/10 even, were really interested, we're talking about 30 or 40 people. That's a lot who can achieve a lot as well. And I think, if you don't mind, I'm going to make use of the participant lists, and I'm going to send you things about about evidence-based healthcare. I would consider you a critical mass that we can invest in you in terms of developing systematic reviews, developing guidelines, and so on, so we can work together and learn together on the way. The next ISEHC conference, as you've heard from Nino this afternoon, is going to be held next October, so a year from now, and it will be on 2023. from the 25th to the 28th of October, and it will be held along with their conference, the GIMBI conference, so it will be held in Sicily. And I've been to that conference many times. It's about the teachers and developers of EBM, and you can enjoy Taormina, and you can enjoy the conference, and the networking that takes place in that conference is magnificent. One message as well from Kameshwar Prasad, who's the president of ISEHC. He said that the membership is $20. So if you want to become a member of ISEHC, that's it's relatively cheap, and you can be informed and be part of a larger community of those interested in evidence-based medicine and those interested in developing, teaching, and all the themes that we've talked about in this conference and much more. So we'll send you details about this as well. And I think that's it. If we didn't have any comments from you or anything that you would like to share at this stage, it would be nice to have your feedback. If there are burning things that you feel you want to share with us, please let us know. Thank you. Thank you for the kind words. And so it seems that this is the end of this conference, but it's the beginning of more input and more emphasis on evidence-based healthcare in your lives and in your practice and in making policies. Reflect on what have been said, have the time to watch the videos again. And I hope that we'll meet again in other events, at least in the one in Sicily. Okay, thank you very much for your patience. I would like to thank as well the hosts, Dr. Amr Jamal, and on behalf of the Evidence-Based Healthcare Chair and Research Chair in King Saud University, and to thank Dr. Saidi and Mr. Ahoud, for the wonderful job from the National EBM Center at the Saudi Health Council. And last and not least, the Virtual Medical Academy, all the staff who have done wonderful job and were available around the clock. Muhammad Jamal, I'm worried that I would be missing مين يا إسراء طبعا. إسراء تذكريني بأسماء البقية اللي شاركوا، وعلى رأسهم طبعا دكتور خالد شحات, who is the president of the VMA. Sultan Bayusuf and Muhammad, another Muhammad, and so on. So it has been, we're really very proud of you. And I would like to thank, of course, these speakers. They have done a wonderful job. Most of them, we've lost few of them as a result of postponing the conference, but and we've lost one or two during just by not communicating, not being able to communicate with them, but with the difference of time zones and the influx of so many emails at the moment. Probably we're just drowning in emails, and it has been missed one way or the other. Of course, to thank the audience. Thank you very much for your what you did, for being with us, for supporting this conference, and say goodbye.